Good evening, welcome, and thank you all for coming to the Philadelphia Public Health Grand Rounds on access to primary care in Philadelphia, scope of the problem, identifying solutions. I'm Michael Halpern. I'm a faculty member at the Temple University College of Public Health and a member of the Public Health and Preventive Medicine section of the College of Physicians of Philadelphia. I'd like to welcome you and to explain a little bit about the goal and objectives of the Philadelphia Public Health Grand Rounds. These are free events open to the public and held 3 or 4 times per year. The purpose of the Public Health Grand Rounds is to address important public health issues that affect the Philadelphia region, to include local speakers from multiple disciplines and perspectives, and to generate new ideas and collaborations and overall strengthen the public health community in the Philadelphia area. The co-sponsors are the College of Physicians of Philadelphia and the Philadelphia Department of Public Health. And I'd also like to acknowledge the support of the Independence Foundation. Following the Grand Rounds presentations, I will be introducing the speakers in just a minute. We will have a question and answer session. There'll be a microphone set up in the center aisle. So at the end of the presentations, the speakers will come back on stage, and please line up if you have questions, and we encourage questions from the audience. So please participate in the question and answer session. Please complete the evaluation form, which is on your chair. And we also ask that you consider supporting the section on public health and preventive medicine of the College of Physicians. Think about becoming a member of the section. And to be a member of the section on public health and preventive medicine, you don't need to be a physician. You don't need to be a member of the College of Physicians. The membership is open to all who are interested. We also want to point out that you have the opportunities to support the section by making a donation here or on the website that's listed on this slide. Please also stay after the Grand Rounds for reception, which will be held just through those doors there, which is a terrific opportunity to network and meet other people in the public health community in this area. The next Public Health Grand Rounds, which is the last one for this cycle, will be held on May 15th. Again, it's a Wednesday at 5:30 p.m. on hypertension prevention and control. We hope that you enjoy this Public Health Grand Rounds and consider coming to the next one in May. I'd also like to thank our institutional sponsors who are listed on this slide. We really appreciate their support. I'd also like to thank Julia from the College of Physicians, who did the terrific graphic that you'll see on your program, which we've used kind of as the logo for this issue of access to primary care. So with that welcome, I'd actually like to introduce the topic tonight, access to primary care in Philadelphia. As most people in this audience are probably aware, the U.S. healthcare system is facing a number of serious challenges. There's high and increasing costs, certainly compared to other developed countries. The population in the U.S. is showing increased longevity and increased aging, which is a good problem to have, but it's also associated with increased disease burden and shifting of healthcare issues towards multiple chronic conditions. Patients and families are better informed, which is also a good condition to have, but it leads to wanting and being informed about more personalized aspects of care. In addition, non-clinical factors, including social determinants of health, are now really well known and recognized to be important for aspects including access to care, quality of care, and health outcomes. More than a decade ago, back in 2007, the Institute for Healthcare Improvement came up with what's called the triple aim as a framework or approach for looking at ways to optimize health system performance. The triple aim, as the name suggests, involves 3 components that healthcare systems can focus on in order to improve their delivery of care. improving the patient experience of care, which includes both quality and satisfaction, improving the health of the populations they serve, and reducing the per capita cost of health care. All three of these aspects are relevant to the issue we're talking about tonight, access to primary care. So with respect to improving the patient experience of care, we know that individuals who have a usual source of primary care have a better experience of care. They tend to have greater satisfaction with their health care. They tend to give their doctors higher ratings, and they tend to indicate fewer unmet health needs. Regarding improving the health of population, again, individuals who have a usual source of primary care usually have better health care needs addressed. Individuals with a usual source of care are more likely to receive preventive services, including childhood vaccinations, blood pressure and cholesterol screening, cancer screenings, smoking cessation, and other sorts of preventive services, as well as being more likely to receive treatments such as hypertension and hypercholesterolemia control. Finally, with regards to looking at the per capita cost of care, individuals who have a usual source of primary care tend to have lower rates of emergency department visits for non-urgent conditions, fewer hospital admissions, and in particular, lower hospital rates for preventive hospitalizations, shorter hospital stays, and overall lower costs of care. So clearly, in terms of looking at optimizing the performance of both local and national healthcare systems, paying attention to primary care and access to primary care is a critical issue. With that introduction, setting the context, I'd like to introduce tonight's speakers. Our speakers tonight are Raynard Washington, who's the chief epidemiologist from the Philadelphia Department of Public Health, David Grande, who's the associate professor of medicine at the University of Pennsylvania and director of policy at the Leonard Davis Institute of Health Economics, Andrea Vittori, who is clinical director at Mary Howard Health Center, which is part of the Public Health Management Corporation, PHMC, and Ellen Ricobene, who is the medical director at Independence Blue Cross. More detailed information on each of the speakers is available in your program. With that introduction, I'd like to invite the first speaker up. We will have all four speakers come, give their presentations, and then the question and answer session. Again, thank you for being with us tonight.
Thanks a lot, Michael. And I'm not sure if I'm supposed to be using this one or, can you guys hear me? Yeah, okay, great. There we go. So tonight I'm going to try to give you guys a very high-level overview of the status of access to care in Philadelphia. Last year, the health department decided to, recognizing that access to primary care is a critical issue for the health and well-being of all Philadelphians, we decided to develop a special report that would actually sort of collectively and comprehensively summarize the status of access to care in the city of Philadelphia. And actually copies of this report are right outside. And so we worked on this report in combination with Dr. Grande and the folks at the Leonard Davis Institute. And so this is really kind of a Part A, Part B presentation, him and I. So you might see a couple of slides that look the same, but we are trying to drive home the same points. One of the things that we quickly recognize in our work to think about how to define and measure and report on access to care, it's a really complex sort of concept. There are various components, and I've tried to sort of organize them in this slide the way we thought about them when we were thinking about drafting the report. And beyond sort of, I'm going to walk through this in just a second, but beyond that, it kind of helps sort of set the stage that access is a big word. It's only like, you know, how many words, how many letters? It's 6 letters. But there's a lot of pieces to the puzzle to actually addressing access to care. There are a lot of pieces to the puzzle to try to measure access to care. And as a health department, thinking about our responsibilities to improve the health of folks in Philadelphia, it's even more complex to see if we're actually making any progress. So the first bucket of sort of indicators around access to care is really provider availability. And this speaks to the location, the supply of physicians, actually having enough primary care practitioners in a geographic space within a close geographic proximity to where people actually live, that they can actually go to them. Another component of provider availability has to do with their insurance acceptance, and that's sort of a bridge between availability and accessibility, whether or not providers actually accept the types of insurance, particularly if I live in a neighborhood, if the provider in my neighborhood accepts the type of insurance I have. And that's both private insurance and commercial insurance. And so there's lots of factors around providers' decisions around contracting that influences access to care for individuals in a community. On the provider accessibility side, there's a whole host of sort of indicators that we could conceivably measure or consider to include in the report around whether or not providers who are in communities are actually accessible to the people who live in those communities. And part of that has to do with whether or not they have the capacity to even see more patients, if they're actually accessible, if they have appointments available for the types of insurance they're accepting. And Dr. Grant is going to talk a little bit more about that in a little bit. And also talking about if their hours are accessible. If I work 9 to 5, can I still go to the doctor? They have evening hours, Saturday hours. And then there's other components around accessibility that whether or not my doctor is sort of culturally appropriately for me in terms of providing care. Whether or not my doctor, if I don't speak English as a first language, if they can communicate to me properly, if I'm unable to sort of relate to the physician in many ways culturally, it does have an impact on whether or not individuals choose to access care. And the other two big buckets that I would sort of put this in access to care have to do with the individual in many ways, and these really are what I would say are individual factors that drive access to care in the city. And so one is affordability, and that's sort of the first big bucket that really, if you think about an individual trying to go access any type of service, it's whether or not they can afford it. And so driving affordability really is whether or not you have health insurance, and if you, the type of insurance you have, and then what are the relevant out-of-pocket costs that come along with that insurance. And then there are a whole host of indirect costs that are associated to accessing healthcare, whether you can afford transportation to go get it, whether you can afford to take time off work to go get it. And so being able to afford the care, also whether or not if you have a doctor in your neighborhood, if you have insurance, if you can afford those sort of peripheral costs is really sort of an influencing factor. And the last bucket is sort of behavioral, but beyond behavior sort of really sort of focuses on the individual around utilization. And that's whether people actually know or are aware that they need a primary care doctor, if they elect to have a primary care doctor, where people make decisions about where they seek their care, whether it's at the doctor or how you sort of perceive the use of accessing care. And then what services are they getting when they go to those providers? Are they actually getting the appropriate screenings? And then the last bucket around utilization has to do with the person's capacity to be able to actually go to the doctor, and there are a host of social economic determinants that influence affordability as well as utilization. So I'm going to talk a little bit about sort of some of the key indicators that we collected and sort of reported in the report. I won't go into full detail about all of them, but look forward to additional questions and dialogue afterwards. So what does supply look like in Philadelphia? As I said, Dr. Grant is going to talk a little bit more about supply in the city, but just to give you a very quick snapshot, Philadelphia has a large and increasing supply of primary care practitioners, which is really great news. As you can see in this chart, from over the course of the last decade, we've seen a fairly significant increase in the number of primary care providers in the city, and the number of primary care providers, the absolute number that are accepting Medicaid is also increasing, which is good news. So we have about one primary care practitioner for every 1,200 residents in the city, which is actually higher than the national average, which is great. In terms of how that supply looks across the city, there is a fair amount of variation, and I won't spend a ton of time focusing on all the variation, but I will highlight that in these two maps, the areas that are colored with the darkest shade of blue, the navy blue areas, are areas that had the lowest supply of primary care physicians. And you can see on the right-hand side graph, where you see the sort of highlighting where the darkest areas are, those are actually primary care shortage areas. Those areas actually meet the federal qualifications or definition of a primary care shortage area. Excuse me. And so those areas, while Philadelphia is full of lots of great academic and healthcare institutions, we have areas in the city who have supply of primary care physicians that are lower than some rural communities and areas in the country. And I'll point out especially the a couple of clusters of neighborhoods in the northeast, the far northeast, or the sort of lower northeast here, and so the river wards, as well as in the southwest region where the supply of providers was very low. And I'm going to make this point here because you'll see kind of a pattern as I'm sort of talking about a couple of the other indicators where supply is low, but there also are other factors that are also influencing access to care in those areas, which really make those really key targets for primary care access as we think about where our biggest opportunities are for action. Community health centers, so the map on the left-hand side shows you where all the community health centers in the city are. There are approximately 46 community health centers across the city. They are an essential component of our healthcare safety net. They provide care, in most cases, they provide primary care to the large majority of individuals who are not insured in the city, and a large majority of individuals who are on Medicaid. You'll notice that the community health centers actually kind of clustered towards the center of the city. And there are a couple of areas, particularly in the northeast, where there really aren't any community health centers. There's just one in the northeast, and that's actually Health Center 10, which is the health center for the health department. So keep that in mind as I'm talking. You'll see a little bit more about why I think that's important. And on the right-hand side, you can see these are where the hospitals are located. So we do have pretty comprehensive coverage of hospital facilities, acute care facilities. But again, assuming primary care access is actually happening and people are using it, we would hope that they would only have to use those acute care facilities for the most extreme cases. Moving ahead, so switching now gears from supply to think a little bit about the people level measures. This is actually a graph of the percent of Philadelphians that are living without insurance. So the gray line shows you the rate of uninsurance, and the green line shows you the percent of individuals that are covered by Medicaid. And so the very good news here is that over the last 5 years, uninsured rates in the city among adults ages 18 to 64 have declined by about 50%. So now the estimates, we estimate around 10% of adults in Philadelphia are without insurance. And we attribute much of this decline to the Affordable Care Act and the Medicaid expansion. So you can see as uninsured rates go down, there's a nice increase in Medicaid rates, but it's not exactly comparable. So there are some individuals who are accessing insurance not via Medicaid. So that's adults. And children, also good news, about less than 4% of children in Philadelphia are without insurance, those that are less than the age of 18. You can see, though, just over half of the kids in the city are covered by Medicaid. Just to sort of point out some of the characteristics of adults who don't have insurance, individuals without insurance in the city tend to be much younger. They're commonly males, or they're more likely to be male than they are female. They're more likely to be racial ethnic minorities. But the biggest sort of disparate group in terms of insurance access really is those individuals who are foreign born, particularly those who are not naturalized citizens. And so there's a large, and as everyone knows, Philadelphia has a very large immigrant population, and those who have not naturalized as citizens, the rates of uninsurance are dramatically higher than they are in the foreign-born naturalized, as well as those who are citizens. In addition to some variation by subgroups, there's also variation in insurance status by neighborhood and geography. The map on the right-hand side shows you uninsured rates in the city by census tract, and you can see there are some clusters of uninsured rates, particularly in the Northeast. And you remember I mentioned earlier the area of the town that has like one health center is where we have some of the highest rates of folks without insurance. And similarly, there are some clusters also in the Southwest region where we had the low supply of primary care providers, where there are a large number of individuals that don't have insurance. And so it's really important to think about as we think about planning and identifying where the healthcare safety net is actually located, that we target areas where we don't have adequate resources, but we have a large demand in terms of the individual population that's there. And the map on the right-hand side shows you exactly where the sort of the density of Medicaid patients, and you can see in some of the lower income census tracts, you will see higher rates of patients with Medicaid, as you might expect. Moving a little ahead to some decisions about sort of adults with a primary care doctor. So roughly 18% of adults reported not having a primary care doctor. And as Michael's already sort of made the case for, adults that don't have a primary care doctor elected are much more likely to not have a usual source of care. They tend to miss recommended preventive care. They delay seeking care, which often results in them showing up at the emergency department or being admitted to the hospital. And so really having a primary care provider or having a usual source of care that's not the hospital is really, really important. And you can see the biggest determinant for not having a primary care doctor is not having insurance. And so the layers of individuals who are then, great, that's my warning sign. So the individuals who don't have insurance, who are low income, are certainly more likely to not have a primary care doctor and more likely to end up in the hospital emergency room if they have some acute care. Another measure that we have included in the report, sort of I'm running through a whole gamut of things, so just bear with me, is the number of hospitalizations that are potentially preventable. So individuals who show up in the hospital for conditions like asthma, diabetes, and hypertension that we believe if they actually were managed well in the primary care setting, they wouldn't require hospitalization. So over the last decade, we've seen pretty significant declines in the rates of these conditions in the city of Philadelphia, but there still persists some really high disparities in individuals who are Black and brown, particularly as it relates to the number of individuals being hospitalized for conditions that we believe could be potentially prevented. And the reality of this, this particular measure, it really is just a reflection of what we think might be happening in the community. So some of these hospitalizations are very likely appropriate, but this allows us to sort of give a relative measure of what's happening. Along with hospitalizations, really for sort of broadly looking at the whole population, the health department has focused in very specifically on kids with asthma as a very good example of a measure of whether or not individuals are accessing primary care. Individual children who are, so a more specific measure really is understanding kids whose asthma is controlled in a primary care setting should not end up in the emergency department or in the hospital, theoretically speaking. And so looking at the number of kids that are hospitalized for asthma, which we do believe are really preventable with many sort of interventions that could happen in the home and in the community, we can keep kids out of the hospital. And so you can see from this graph, we've seen some declines in the number of kids that are being hospitalized for asthma. And there really is a lot of variation in terms of where these kids are coming from. The communities, particularly in North and West Philadelphia, where there are high rates of poverty, high rates of poor housing conditions, really are driving individuals to not be able to manage their asthma, or families to not be able to manage their kids' asthma at home. So I'll start with some just key priorities I think the health department is really focusing in on as it relates to primary care access in Philadelphia, and look forward to more dialogue after all the speakers have spoken. The first one I've already mentioned is really expanding access to primary care services in low access areas, particularly in the Northeast where we really don't have much of a healthcare safety net, and in the Southwest corridor. The second point really is around accessibility to making primary care services accessible for everybody, not just folks who have private insurance, but ensuring that all providers are actually accepting Medicaid. And then when individuals don't have insurance, they're still able to seek and receive care outside of the hospital setting. And the third thing is around increasing awareness about using primary care and actually getting people to elect to have a primary care provider, particularly among some of those key subgroups that I mentioned. And the last one, which is of course important, is really improving the management of chronic conditions, both in the primary care setting, but also in the home setting, to avoid those sort of residual complications and hospitalizations that result. Thanks.
All right. This working? So this is probably a familiar picture to many in the room. This is a headline from January 1976, when a lot of the reporting started in Philadelphia, really focusing on the quality of care at PGH. And I put this slide up here for a couple of reasons, but the most important reason, I think, is to think about this conversation in Philadelphia, as we think about the healthcare safety net, is fundamentally different than the conversation that happens in many other large US cities where we still have a public hospital, where the public hospital system becomes an organizing framework to really think about how to organize a safety net throughout the city. So if you look at work that's been done, for example, in San Francisco to create the Healthy San Francisco program to try to create a more integrated system of care in the safety net, that again was anchored by a public hospital. Similar things have happened in LA. New York City just announced plans to try to come up with a system of what they're calling universal health care, which again is really anchored around the public hospital system in New York City. So we deal with a very different landscape as we have this conversation in Philadelphia. And it's not to say we can't solve these problems, but it requires the community around healthcare to come together in different ways to solve these problems than in some other cities. I'll also point out that if you look at the top left there, the job of a meteorologist is much harder today. So it says up there, tonight rain, tomorrow mild. So apparently that's all you had to do for the forecast. I think maybe some of us could have even pulled that off. So this is a picture taken more than 6 years ago of Health Center 10, really trying to draw attention to, I think, some of these problems that are not new and really demand our attention and trying to come up with solutions. And Health Center 10 that Reynard pointed out has been a part of, in the city of Philadelphia, where there's clearly big stresses on primary care access in the city, but not the only place, I think, where that's the case, but one that's the most acute. A framework that was published in 1981 looking at issues of access really called out these 5 different areas, and I won't read them all off to you. Reynard touched on similar concepts, other than to say, you know, there's been a lot of attention through the Affordable Care Act on number 1, which is around affordability and all the conversations around health insurance in America, health insurance here in Philadelphia and Pennsylvania. And I think a lot of our conversation here tonight is really about the accessibility of primary care, and I think that often gets lost in these larger national conversations around health insurance coverage, though all of these issues are clearly important. If you look at why it matters in terms of thinking about the availability and supply of primary care in areas where people live that's convenient to them, this is probably one of the better studies to look at this issue. It was published in JAMA in 2011. And they used a unit of analysis, something called primary care service areas, which have been developed as part of the Dartmouth Atlas, where they try to develop what are essentially little markets for healthcare. And in primary care, they look at using largely Medicare data, where patients tend to go for care based on claims, and create kind of like little healthcare neighborhoods from that. So in the city of Philadelphia, I forget the exact number of primary care service areas we have, but it's not a huge number, so it's not like a census tract level analysis, but probably more in the order of like 10 or 12 of them here in Philadelphia. But these analyses show that in areas that have more primary care, that there is indeed lower mortality, that those ambulatory care sensitive hospitalizations that Reynard talked about are indeed lower in areas with better supply. And then at least using Medicare data and looking at what happens to healthcare spending, there's really not much of an effect. So I'm a general internist, so that's a little disappointing. But what you see, I think, is a reflection of perhaps more value in healthcare to some extent. So less spending on acute care, okay? So if we have the unchanged levels of overall spending, but we're seeing less spending on acute care, I think that reflects something positive happening in areas where people live, where there's a greater supply of healthcare. So Reynard showed you this picture, and I think, again, just to frame the conversation, I think when we think about the city overall, we see a rising number of primary care physicians. We see this little, let's see, does this work? Yeah. We see this little spike here happen around 2013 in terms of the percent of primary care physicians accepting Medicaid. It's important to point out what was going on around this time, which was a temporary increase in the reimbursement rates to primary care physicians through the Medicaid program. This has subsequently gone away in many states. This was a provision of the Affordable Care Act. And studies have shown that, not surprisingly, when you increase reimbursements in Medicaid, more primary care physicians participate in Medicaid and take new patients. And that's been borne out in states all around the country, and looking at what happened with that fee bump that happened around 2013. This is that same picture that Reynard showed you, so I'm not going to dwell on it too much, and we're going to take a little bit of a deeper dive. What I want to point out is just, you probably have some difficulty seeing these numbers if you're in the back of the room, but there's about a 10-fold variation between the highest supplied areas and the lowest supplied areas in Philadelphia. So though we have a story in our city of an overall, what I would say is a pretty healthy supply of primary care compared to other parts of the country, we see these enormous variations that end up mattering a great deal where you live and what kind of access you have to transportation resources. When you look at how these areas that are less well supplied differ in terms of the demographics than the higher supply areas, there really is a fairly prominent story that's connected to race. And so what you can see here is these lower access areas have a much greater share of the population that's African American than compared to these areas that are higher access. And in fact, we had done a look at this a few years prior, and this is some results that we published in the journal Health Affairs, trying to really unpack what was driving these variations in Philadelphia. And so I'm going to zoom in on this first part here, and you can see there was an enormous effect of really looking at neighborhoods where census tracts were 80% or more African American, had an enormously increased risk of being in these low access areas. It wasn't the whole story. There were certainly other aspects to this, including the uninsurance rate, for example, was another independent predictor of areas that had lower supply. But the kind of racial aspect to this story was clearly the more overwhelming driver that we see. When we think about appointment availability, so the way we look at this, the work that we did in our research team is doing mystery shopper calls to practices and trying to make appointments, okay? Try to do our best to simulate what a patient would be going through. So it's often hard to call practices and just ask them as like a part of a survey, you know, how's your appointment access? You know, are you offering new appointments today? How long's the wait time? And so the best way to really look at this is to just call and simulate a patient and see what happens. And so what we found in Philadelphia is that there's certainly a difference between Medicaid and privately insured individuals. So about 70% of Medicaid callers were successful in getting an appointment, and about 87% of those with private insurance were successful. One thing that's important to point out, these calls for our Medicaid callers are only to Medicaid participating providers. So if you look at the choice set that people on Medicaid have, it's actually substantially lower than this 70%. So this is telling us that 70% of Medicaid participating providers were offering new patient appointments. We have data from other cities where we've done similar work to compare us, Philadelphia to other places. So certainly we're not the worst off. There's some other places that are substantially worse. So like work we did in Portland and San Antonio, Dallas, these are places where Medicaid access is actually quite a bit worse. So that's not to say this isn't a problem. It's maybe just to say it's not quite as bad here as in other places, though it's still clearly a problem. This just looks at some of the neighborhood variation in appointment availability. So in general, again, this is the map of our private calls. And in general, appointment availability was quite high. When you look and compare that to Medicaid availability, again, you'll see in general, the whole map is a bit darker, which reflects these lower appointment availability rates. But at the same time, we still see substantial variations, so much lower appointment availability in South Philadelphia, and these areas that Reynard pointed, about 62, 63%, and even up here about 61%. So this doesn't perfectly map onto those supply maps that I showed you earlier, so it should tell us that there's other things that matter here other than just how many doctors are located in your neighborhood, and those make the story much more complicated to think about solutions. But I think in general we can certainly say that a lot of the data certainly argues for some issues up here in the lower northeast, as Reynard pointed out. And then when you look at wait times, so when we would be offered an appointment, we would actually take the date of the appointment, and then we wouldn't take the appointment. We would then tell them, never mind. So we weren't holding appointments, but we would actually get an appointment offered to see exactly how far in the future it was. So there was some clear differences. So privately insured individuals in general had about a 9-day wait, and folks on Medicaid had about a 16-day wait. Again, I want to point out these are for new patient appointments, it would be almost impossible to do a study like this and try to portray yourself as an existing patient in a practice. So if anyone has any ideas how to do that, please let me know. Just a couple caveats. So this is work that was published in 2013. It's at the county level. It's not at the neighborhood level. And it does give us pause for a moment to see how this idea of wait times and availability is directly connected to supply. And at least at the county level, these more macro analyses, there wasn't a very strong relationship, but this is, again, has a lot of caveats to it because it's county level work, and also what is reflected in this is appointment availability in terms of wait times, I think, for existing patients in practices and self-report of physicians. So some key points I want to make to wrap things up. So I think overall, we have a pretty good supply in Philadelphia of providers, and it seems high enough on average to hold down wait times. I think clearly there are issues for people on Medicaid in certain parts of our city with gaining access. I would say that there's clearly the anecdotal evidence, and also from our data, there are a small number of clinics that have very long wait times. And some of these places tend to be what I would call the safety net of the safety net. So the places like Health Center 10, where there are very high uninsurance rates, where patients often struggle to have any alternative choices. We don't have much that we can really say from our data on what the experience is for once people have already gotten in the door, and whether that differs much compared to new patients. But clearly some neighborhoods are much more well supplied than others, and racial disparities are a very important part of this story. But certainly, you could do an enormous amount of additional work to try to really unpack this further, to understand all the other issues that I think that are important to access beyond how close, what the supply is immediately around where you live, and what the availability is for appointments, but also things like transportation barriers, which brings into conversations things like public transit routes, people's individual level mobility, and individual preferences for providers. So not everybody necessarily wants to go to the primary care provider that's closest to their home and maybe is the easiest to get to, but may have preferences for other providers that they would really like to see. And then I think there's a broader social question, which is, are the issues that we're seeing in healthcare access really reflecting deeper issues of scarcity of resources in certain neighborhoods? So if we think not just about healthcare, are we really seeing just a replication of many of the other challenges that we're seeing? And I'll just end with this map again to show you. This was what our supply map looked like in 2016. This is a map on limited supermarket access from 2015. And there's a lot of overlap with these darker areas in the same exact places where one sees limited supply of primary care providers. But what I want to point out is, this map was redone in 2013 and showed a lot of these areas had disappeared. And the reasons that they had disappeared is because there was very deliberate public efforts to address these areas that were undersupplied with food access. And this problem that we're talking about today will not just solve itself. And I think that's why it's important we're having this conversation today. I think the challenge is bigger here because we don't have a public hospital system that naturally becomes the kind of leading point of solving these problems, and requires the community to really come together in a very deliberate way to address these access issues. So thank you.
The report that both Dr. Grande and Dr. Washington referenced, one of the recommendations at the end of that report was to help some of the community health centers that are in the process of transitioning to federally qualified health centers complete that process as one of the ways of increasing access. So I thought that's a nice sort of segue into this part of the discussion that we're having tonight. And so my background, I'm a nurse practitioner. I run a community health center that is specifically serves the homeless population in Philadelphia. And I have worked with, in community health center settings, both as a nurse and as a nurse practitioner in Boston and in Philadelphia. And I can tell you, I'm very passionate about the work that we do, and I'm passionate about the way we do that work and provide the services that we provide. And I think it's that unique way that we do that that really helps to increase the access to care. So I'm hopefully going to take us out of some of those hard statistics that we had, and hopefully put a little flesh on the topic, and talk about some of what we're doing at the grassroots level to address this care for access. And I titled this a community and government partnership because I really think that the unique thing that about community health centers is that they are a partnership between the federal government and the local communities. And that partnership is really what has made the difference in the outcomes that we see nationally around the work that community health centers are doing. Community health centers are nonprofit organizations. They can be private or federal, but they are nonprofit organizations providing care to increase the access to vulnerable populations. And again, that is really the key to what community health centers do. Our mission is to increase the access to vulnerable populations. So nationally, community health centers serve 28 million people in 1,300 health centers in 9,000 locations across the country. In Philadelphia, we have 44 health centers, and we serve roughly 280,000 patients in the city of Philadelphia. The safety net populations that we serve, the uninsured, the underinsured, low income, migrant communities, folks who are homeless, and residents of public housing. Those are the populations that we target, and those are the populations that we really feel like we can serve best. One of the things that make, I think, community health centers so successful is we offer services that are really outside the traditional scope of primary care facilities. So, for instance, we co-locate a lot of services under one roof. So you'll see in community health centers both primary care services alongside of dental services, ophthalmology services, cardiology services, podiatry services, and I'll give you a real life example. I mean, in our health center where we serve the homeless, many of our patients are either mentally ill, many of them are cognitively impaired, and so for them to leave our office with a script or instructions to, first of all, make an appointment to a cardiologist, to then be able to navigate the system and get into the office and see that cardiologist and then successfully report why they're there and report back is nearly impossible for many of our patients. So co-locating those services under one roof is really, really critical in the care that we provide. Community health centers, the federal government provides health oversight of the community health centers through HRSA's Bureau of Primary Health Care. And I referred to federally qualified health centers because that's really what we're referring to when we talk about community health centers. And federally qualified health centers are a very specific and unique type of community health center in that they receive funding through Medicare and Medicaid reimbursement dollars and also federal grant dollars. The requirements, in order to be a community health center, there are 19 program requirements that that really need that programs need to abide by, and those program requirements really govern the way that we provide our services, the finances, the oversight, the management of the services. And I pulled out some what I feel are really core requirements of the work that we do. So to be a community health center, we have to see anybody, regardless of their ability to pay. So uninsured, underinsured, private insurance, it doesn't matter. We see everybody that walks in the door. Now, we have to establish a sliding fee scale for those patients. So there's a misconception out there that community health centers are free health centers. They're not, and we can't be. The federal government requires us, as a way to make sure that we're sustainable, to establish the sliding fee scale. Now, most of the patients, for instance, at the health center where I'm at, are fee assessed at 0, so they don't pay anything because they don't really have an income, but we are required to do that. One of the really unique things about community health centers is that they are community-based, and the federal government requires that 50% or greater than 50% of the board is represented by community members. And so that unique partnership really allows local members of the community to have a say in the health care that is provided to them. And that's one of the things that has really helped make community health centers as successful as we have been. In order to be a community health center, you have to have a federally designated underserved population that you're serving, or in a federally designated underserved community. So rural Appalachia, the parts of Philadelphia that were referenced earlier that were physician shortage areas, or it can be population-based. So for instance, the community that I work with, the homeless, that's would be considered an underserved population by the nature of the population itself. We are required to provide not just quality care, but quality comprehensive care to patients across the lifespan. So primary care, dental services, behavioral health services. We provide substance abuse services to patients and pharmaceutical services as well. One of the things that's really, I think, unique in Philadelphia, excuse me, is the embedded, can I have that water? Excuse me. Philadelphia has been really nationally, the community health centers in Philadelphia have been nationally recognized for the work that we do in embedding our behavioral health services into the settings that we work in. So, you know, there's co-locations of services, right? So you can have a psychiatrist under one roof, and you can have your primary care providers. We take that a step further, and we actually weave those services together. So what do I mean by that? So for instance, I'm seeing a patient in the center, and it comes up in conversation that there's some concerns around depression, or I noticed that there's some issues that are really preventing this patient from really accessing the care that they need and achieving the goals that we set out for them to achieve. I can pick up the phone and I can call behavioral health specialists in the moment, and I can say, you know what, so-and-so here is having a little trouble. There's some barriers here for them taking their medicine, getting their medicine, whatever it is. Can you come on in and have a conversation with that? And that provider comes in the moment, right then and there, and talks to that patient. So there are no missed opportunities. You know, I could say to that patient, you know, you really could benefit from behavioral health, and how about I schedule you an appointment? Well, the likelihood that that patient's going to come back for that appointment is pretty low. We're also required to provide supportive services. So all of the health centers, and the network that I work in, we have 6 health centers, and every single one of those health centers has a social worker. And that social worker helps the patient access transportation services, helps them decrease those barriers, whether that's something as simple as providing tokens, connecting them with the logistic care that can provide transportation to their appointments, translation services, outreach services, health education, whatever those services are that are needed. I'm not a historian. I'm not going to spend a whole lot of time on this, but working in community health centers, I actually find that there's a sense of pride in kind of looking back and seeing where our roots are and where we came from. The roots to the community health center movement really starts back in 1960 with Lyndon Johnson's War on Poverty. And I think it's important to recognize, again, tying into that community, thank you, tying back to that community based care that we provide, this really came about because of activists at the local level, really stepping up and saying, no, there are vulnerable populations out there that need access to care. And so I'm getting short on time, so just quickly say, so that led to, in 1964, the Economic Opportunity Act, which really gave rise to the community health centers and led to 2 demonstration projects, one in Mount Bayou, Mississippi, and the other in Boston, Massachusetts. And those demonstration projects proved so successful that eventually led to the permanent authorization of the community health centers in 1975. So what are some of the successes of the community health center movement? Well, I mentioned earlier patient involvement. That really was a game changer for healthcare in community health settings. The patients now have an actual say in the care that's provided. And I can give you a real life example of that. So again, the center that I work at, we're homeless. Our patients said, you know what, we need access early in the morning because we have to leave the shelters early in the morning and we have to be back late in the afternoon. So we shifted our schedule to meet the needs of our patients. So we open our doors at 7 o'clock and we stay open until 5 o'clock. That's just a small example, but one that demonstrates the role that patients really play in the care that we provide. Community health centers have demonstrated nationally that they've improved access to primary care services, again, in the way that we conduct those services. And we try as hard as we can not to miss opportunities so that when patients walk in the door, we're always looking at immunizations. We're looking at cancer screenings. We do chart preps before patients come in the door. Our medical assistants prep the charts for things like colorectal cancer screening, Pap smears, whether or not their immunizations are up to date. And we capture those right then and there when the patient is there. And if they can't access those care, so we have patients who, because they're homeless, they can't get their colonoscopies. We have a center now where patients can go overnight and they can prep for their colonoscopy, and then we can help them with transportation back and forth. So it's those kinds of things that that we do that are very organic and very real to patients' lives that I think really make a difference. And nationally, those differences have really borne out. Community health centers have been recognized by the Institute of Medicine and the General Accounting Office as either meeting or exceeding national standards of the care that we provide. So we're meeting standards in terms of care to our diabetic patients, to our hypertensive patients, to patients with asthma. Community health centers, because of the improved access, have fewer infant mortality rates, and patients by far rate the satisfaction of community health centers as high. Community health centers also have been proven to increase cost savings for patients, for healthcare across the board, and in large part that is because of the improved access that we provide. Stimulates the local economy. Health centers hire from the people that live in that economy, and so we improve access, we improve the economic availability for people in the neighborhood, and reduce health disparities as well. So that's just a snapshot of what we do sort of at the local level, and I'll be happy, at the question and answer to unpack some of that a little bit further.
So, unlike my 3 predecessors, I work for Independence Blue Cross, so I'm coming at, it's going to be a little bit different now, this discussion. But I promise you, it should be interesting. Okay, there we go. Okay. Independence Blue Cross, I've been there 11 years. I really enjoy working for this company because basically they embrace their mission statement, which is to enhance the health and well-being of the people and the communities that we serve. And every meeting, that large meeting we have, we start with that, and we are passionate about it. We serve about over 1 million commercially insured people in the Philadelphia region. 188,000 of those are people who have bought health care through the exchange. In addition, we serve about over 100,000 Medicare members, just to give you a sense of who we are. We do have a sister company, AmeriHealth Caritas, which is our Medicaid company, but what I'm talking about now is all about basically Independence Blue Cross, not the commercial and the Medicare, but not the Medicaid product. So we'll talk about access. You've heard about access already. And just suffice, I'm going to kind of speed through this a little bit, that basically at Independence Blue Cross, we're committed to ensuring the adequacy of our network. We do this on an annual basis and present it to our board of trustees. There's a lot of tools that we use, including census data. We take member complaints and address issues to access there. We also take, information from our providers about languages. So there's a lot that goes on there, and basically, you've already heard, we have a robust primary care network in Philadelphia. We also do the same for specialty care, making sure our network is adequate for specialty care and also for behavioral health. And we exceed the standards set by the state, NCQA, and federal governments on that. So before I move on, I just want to say is, what do you all think about, access and telemedicine? Do you think that telemedicine in Philadelphia has been embraced? Would you say yes or no? No. Okay, and why do you think that is? Because number one, we have a great access to primary care, but what else do we have? We have lots of urgent care centers and retail clinics. So we're not seeing a real embracing of the telehealth movement in the Philadelphia area. But I also want to tell you, with this robust primary care network, guess who's not going to the primary care doctor? And there's a number of you in the room. It's the millennial generation. And have you heard this? That basically, where are millennials getting their health care? Urgent cares, retail clinics, not telehealth yet, but that's what they're doing. So I just want to tell you, so I'm going to circle around to that. So we have great access, but not everyone's using it. So quality. In Philadelphia, there's trends that come through, and it used to be consumer-driven healthcare. Now what we have is value-based care. And so every contract that we do, it's not just straight fee-for-service anymore. You have to have some skin in the game if you're an institution or if you're a large physician group. We want quality, returns on that as well. Our quality program for our physicians in our network has been around much longer than that. It's been around over 25 years. So it's our QIPS program, Quality Incentive Payment System, to reward primary care for good quality in addition to the payments that they get for seeing people. And so primary care, family practice, internal medicine, and pediatrics. I'm sure you're not surprised. These are the measures that we use. They're set by HEDIS. There's immunizations, well care, cancer screenings, and diabetic care. And at the end of every year, we come up with a scorecard, a report card. And because we know that, to give effective feedback, we compare your office to your peers, how you did in comparison to your peers. So this has been around for 25 years. What do you think has happened after 25 years? We saw when we first instituted it, care quality started rising. And what do you think, what's happening now? It's plateauing. So after 25 years, we need to shake this up a little bit. So what do you think that we did, a few years ago, what we started doing to kind of start bending it and kind of trying to improve care, get those mammogram rates past the mid-70s. So what do you think we did? We threw data at people. Okay, so we created lots and lots of reports and sent them to doctors. And you know what happened to those reports? You can imagine, right? They went right in the circular file, right? So we just inundated them. But look how great this is. We're sending them a list of patients that they haven't seen in the past year, many of whom have chronic conditions. And so if you think back on that report card, we have an office that basically said, oh, I'm a tier 1, I don't have to worry about this. And I said, well, actually, you barely made it into tier 1, and you haven't seen, I looked at their list, you haven't seen 20 diabetics at all last year. So you may not be in the tier 1 quality payment. Look at all this opportunity. So I'm going to circle back around to that. So we threw data at people. Here's a nice diabetes report. It's all the diabetic population from Independence Blue Cross. If they're on insulin, or should they be on insulin? They're taking 3 medications and they're still not controlled. Are they going to see that endocrinologist that the doctors referred them to? If they have chronic kidney disease, are they seeing a nephrologist? So we gave them this information. So you can imagine, them would say, what did you think of that report? And they looked at us with blank stares because they never looked at it. So, because they're busy. So, okay, so throwing data at them didn't really change much. And so now we're at this current stage, and this is actually exciting because I just kind of joined this group about 8 months ago. So we're going to kind of continue to think outside the box, and if you all have any ideas, I'd love to know them. But what we decided to do is not just throw things at people, throw information, but to go to them and to have meetings with them and to share the data and to discuss it. So we hired 4 population health specialists to go out to all the offices that would have us in the Philadelphia area and meet with the doctors, meet with the office managers and the staff, and kind of discuss why people aren't getting their mammograms. What's the barrier in their office? Is it resources? Is it thinking? Anything that we can do to help that. Our population health specialists found that in some of the smaller offices, you may not be aware, but Philadelphia has a very large number of independent physicians that are not associated or owned by health systems. They're associated but not owned by health systems. I was, surprised. So really we have 1/3 of our population is attributed to a health system. 1/3 are completely attributed to independent offices, and 1/3 are part of our physician group which is called Tandem. So they don't have but if you go into these, 1/3 of our offices are independent offices. Do you think that they have a lot of staff? Some of them are federally qualified health centers. So what our population health staff have been doing is going in and making phone calls and trying to help them with the resources. So again, we're thinking outside the box. We're doing different things now. So we had a fit kit program where we mailed fit kits to all eligible people, and our population health specialists came and sat in the office and made phone calls to people. Did you get it? Could you, do you understand how to do it? And could you please send it back? We did that for the first time last year, and we're not sure if it had any effects. We are eager to see the results. So I have the slide up here is because trust is a big word now if you look at the literature about accessing care. And I put this up there for a reason, which is, first of all, if our millennials, and not to pick on you guys, but if you guys aren't going to the doctor, how could you have a trusting relationship with your doctor? And I've also talked to doctors, and doctors have said when we come and give them this data, they say, well, that's your problem. Why don't you deal with that? And we have to remind doctors that the essential point of trust is between the patient and the physician, and that the patients really want to hear it from the doctors. They want to hear that the doctors care about them and that they care about them enough to tell them about the preventive care. And I've actually had to remind doctors of that because it's gotten to that point where they're so busy. And they kind of, want to kind of put that off, and we kind of have to come back and say that. But we take this seriously too. We feel like we have this trust, and so, coming back to the millennials, I had a conversation with someone today, and I said, have you been to a doctor? And he says, I just did because Independence Blue Cross gives me money to go to a doctor. So that's an idea, that's a solution, right? So, paying people to go to the doctor. We actually have a Medicare gift card program. If you go to see a doctor, you get a gift card. So we're actually starting to pay people to do that too. And we're also doing wire messages and email messages to people, trying to increase that trust. So if you sign up, millennials actually, they may not go to primary care doctors, but they are signed up for our email and for our texting. So they do that. So I don't know if anyone here has Independence Blue Cross and has gotten a text. Is there anyone here who has? Oh, someone please raise their, oh yeah, there's some hands there. Good, okay. All right. So what else is exciting that's going on? We talked about behavioral health, and I'm glad I'm touching on something that really wasn't touched on by the other speakers. So part of my job 5 years ago was to go out to our customers who buy our insurance and talk to them about how healthcare dollars were spent. And during that discussion, if they had a pharmacy plan, we talked about the top 5 medications that were that their employees filled. So what do you think they were? What do you think is always in the top 5 types of medications? Blood pressure medications, yes, but why do you think I have this up here? So it's antidepressants, always in the top 5. Now, antidepressants can be used for other things, but they're always there. And what else is always there is pain medicines. So we gave that information to our customers and said, and they looked at it and they said, oh my gosh, we have a huge number of people who are either depressed or have issues with pain. But we didn't have any solutions at that time. So I'm glad to say that we actually have addressed that. And so this is something that this is for our customers. So it does mention, there's some cost value information there. But 1 in 5 adults has an issue with mental health, illness. I'm sure you're aware of that. And they use a lot of resources. And I think only about 10% of them in the past were getting access to kind of, or had any kind of assessment, behavioral health assessment when they went to the primary care doctor. So they use a lot of resources, and then the lead at the bottom is, but if they get treatment, they're not using as much, healthcare resources. They're feeling better. So that's what we and this is kind of the lead that we gave to our customers. And so the next step in the solution is that we just last year in 2017, our partner is Magellan, is that we now have digital tools on our website to that kind of lead you into addressing some of these health issues. And it could be that you kind of feel you're not sure you want to address your depression, but you might want to say, hey, I have insomnia, I want to do that. So it kind of, once you do one, it kind of leads you into the other ones too. We actually sent out about 500,000 emails and text messages to people to access this about, hey, we have these tools. Every time we do that, more people go onto the website and log in. So there are not only just surveys, there's also programs. So there's a 4-part depression module that you can do. There's you can get access to a physician, a behavioral health physician, and other resources there. So basically, just to let you know, so I did this with one of my colleagues just to kind of try it out, and we both kind of answered the questions, and she said she was going to answer them in a certain way, and she you register under your name, and don't you know, her phone rang 3 minutes later because it was a trigger. So if you do answer it, and there's a concern with how you answered the question, someone will call you, and so that was interesting. Okay, so I mentioned telemedicine before. So we don't have a large adoption in the primary care realm, and probably not going to happen for a while. But we think that there's a real need for telebehavioral health, and it's actually a benefit now, but we just don't have. Quite frankly, it's not up and running yet, and the goal is to have it up and running by April. And so basically, we're going to be pushing this out and hoping that we can increase access. So this talk is all about access and increasing people's ability to kind of address these problems. The third thing that we've done, and another thing that makes you feel good, is that basically there's something called CPC Plus, which is the Comprehensive Primary Care Plus program that Medicare is kind of sponsoring, and we've partnered with Aetna here in Philadelphia. And basically, if you're on the level 2 tract of that, there's a behavioral health medical integration that you must embrace to be part of that, and you do receive additional financial rewards. We have 172 practices in the Philadelphia area that now have, and I apologize, it's a little blurry, but now have a dedicated social worker or mental health provider in the practice, so that if you agree to take one of their surveys and you need it, they hand you, there's a warm transfer off to a person right there into the practice. And so they're going to the primary care doctor and getting their behavioral health. So it's a smooth transition there. And they have rounds, there's a psychiatrist there in the lower right-hand corner, because they do consults with the psychiatrist. I know that we're doing this at Penn. Dr. Grande, I'm not sure if you've had any familiarity with that. So, okay, so, and I just want to let you know also is that I mentioned money before. A lot of our customers, we're trying to get them to embrace this, and a lot of people are putting wellness dollars to this, so that not only do you get money as a person if you go to the primary care doctor, but you get money if you come on and sign into these modules as well. So we're hoping for great success. A lot of these things, as I mentioned, just started within the past year. So that's it. Thanks.
I'd like to thank all of our speakers for those terrific presentations. And now I would like to invite our audience members to participate. Please come up, introduce yourself, your name, who you are, what organization you're with, maybe very briefly about what you do, and we'd be happy to answer questions and further this discussion.
Hi, I'm Jim Bueller from Drexel University. I had two questions. The first question is, given the intent of the HRSA primary care program to make sure that FQHCs are located in underserved areas, how do we end up with a situation where we have underserved areas without FQHCs, and how do we fix that? And then my second question, I know that you represented IBC's private and Medicare products, but can you speak at all to the whether on the Medicaid side of the business, if there are similar efforts or how the challenges might differ for trying to introduce some of these innovations into the Medicaid insured populations?
I can speak first to the first question, which is what's wrong in some sense with the community health center program if it's leaving these gaps. I think one of the biggest challenges that we see is that the community health center program is built on Medicaid. And so the entire financial mechanism by which community health centers are supposed to become sustainable is by maximizing the percentage of patients that they see that are on Medicaid, and there's some financial benefits to doing that. And the health centers have to demonstrate, as was pointed out, that they have financial sustainability in their applications to even open the doors in the first place. And if you look at an area like the lower Northeast, where uninsurance rates are still persistently high, despite what we've seen with the Affordable Care Act, some of that has to do with populations who have been left out and still are not insurable under the programs that were created by the Affordable Care Act, and make it difficult for community health centers to come into an area where uninsurance rates are still quite high and thrive in that setting. So I think building the entire program on a model of Medicaid leaves gaps that are not being addressed. It's not to say that we can't be pushing harder and trying to get FQHCs opened up in areas where they can succeed and address some of these disparities. I think there are opportunities to do that. But we also have to recognize that there are some areas where it really is challenging to make a financial go at it.
Yeah, and I would just add to that, sort of in the terms of how the program is built, one of the other sort of deficits is that it's application-based, right? So a community health center organization actually has to want to go to that neighborhood and actually has to fill out the application to apply to go. And so while I do think that there are definitely some challenges with the program's decision-making and being able to sort of determine that you're sustainable in the long haul, the health center networks and nonprofits that run them have to actually apply to provide services in those neighborhoods.
And honestly, I don't know a lot about our Medicaid program, and that's why I kind of made that differentiation. I think it would be valuable to have someone in the future come from AmeriHealth Caritas to speak to that. Are you from AmeriHealth? Oh, there we go.
Hi, I'm Dr. Higgins. I'm the Chief Medical Officer of Keystone First. Under AmeriHealth Caritas with a sister plan to IBC. So we actually have very similar programs. Keystone First cover 440,000 lives in Southeast Pennsylvania. Over 55% of our population lives in Philadelphia County. So we actually all our members are assigned a primary care provider. And what we did was we looked at where they live in comparison to where they're assigned to their PCP. They choose their PCP, or they might be assigned to their PCP. And interestingly, many of them don't live close to their PCP. And what we found is that we actually looked into that population, and we call them, make sure that they are assigned to the appropriate PCP, make sure that they are going to their PCP. And we actually work with our practices. And we actually give them a list of their members that have not seen their provider for over 6 months. So we work very closely with the practices. We also work with all our FQHCs, Mary Howard, all the population. We work very closely with them. We actually pay our FQHCs under patient-centered medical home extra money to care for our members so that they can create community care programs or community-based care management teams to help our members to get into their practices. So I welcome any questions about our Medicaid population in the Southeast region.
I also want to add to what was said about accessing or increasing community health centers in the Northeast. One of the models that our health network experimented with about 1.5 years ago now is partnering with Temple Hospital. And so we've co-located a primary care practice right in the hospital connected to the emergency room. And so, so in addition to patients being sort of tracked, into the green zone if they're more primary care patients, now they can actually be walked over and asked if they want to see a primary care provider right in the facility. And so that, because we have access to those patients and it's more of a sustainable model for us financially, that may be a way to increase the access in some of these other areas.
So thank you so much for your enlightening talk. It was, we were able, I learned quite a bit. So my question was, what role do you think B2B or B2C marketing plays in terms of access to primary care? That's my first question. And I think we tended to focus more on urbanized primary care versus rural primary care, even though we did mention that there is a discrepancy between the Northeast and Southwest in terms of urbanized Philly. And my third point was in terms of, why is it that telehealth, we have a health literacy problem, basically. We don't know what telehealth versus telemedicine would be in terms of utilizing care. And I think, that probably may go back just to education. So I'll just leave it at that. And then fourth question is, we do have a problem, like you mentioned, that there is a discrepancy, once again, with the impact on chronic conditions in terms of primary care, because we go to you for a diagnosis and we're not looking into the retention rates, we're not looking at follow-up rates, and we're not looking at, our primary care initial experience kind of dictates what we're going to do. Does that make any sense at all? And then my last question.
Well, actually, I think 4 questions is enough.
Yeah, so I'll say I do think that from the health department's perspective, health promotional campaigns are a very effective public health tool for influencing and encouraging health behaviors, and so we certainly rely on those in many various sort of topic areas, not just in the space of access to care.
One of the things we rely on heavily are community outreach workers, and so we partner with people in the community because those are the folks that know the patients the best, and that helps us to increase access to care as well.
And the last thing I'll say, and Carol Rogers is here, but she probably could talk about this more than I can, but also just making sure people are aware of what resources exist and where health centers are located and where primary care doctors are and where they can access them is a critical piece of sort of the marketing and promotion component of access to care, I think.
So part of that question had dealt with the issue of telehealth, and Ellen did touch on that. So what are your thoughts in general? Is telehealth a appropriate strategy for increasing access to primary care among underserved populations, or because of there being underserved populations and therefore having potentially more limited access to those kind of technologies, is that not really a viable solution?
I would say from our perspective, where we could really benefit and our patient population could benefit from telehealth is the specialist area. So as I mentioned earlier, a lot of our patients have difficulty accessing specialty care for a number of reasons. There's a lot of barriers that are patient-centered and also system-based. And so if we could connect with specialty via telehealth right in the primary care office, that would really help improve our care for our patients. It's not really addressing the access to primary care, I get that, but it decreases hospital rates, it decreases chronic care.
I would just add that I think that telehealth could be a very important strategy. I think it's way underdeveloped in terms of the availability of what people can actually access through telehealth, but there is a tremendous amount of burden that comes with having to go visit your doctor's office for various needs, and for people who have to miss work and lose income as a result of missing work, if you can streamline access to care and not make people come into the office, I think that that can actually make a big difference for low-income populations who in so many respects are under far greater demands with respect to their ability to get to an appointment and leave work and manage all the challenges with that.
So this is a question for David Grande, but let anybody else chime in on it if they want. I'm still looking at that area in the northeast of Philadelphia that is underserved. And it's underserved because there's a lot of people who don't have insurance, and it looks like the Affordable Care Act has benefited that, but still there's a lot of people who will continue to be uninsured. If anything, that uninsured rate will probably go back up again with what's happening in Washington. So if the Medicaid program is what's driving even the community health center system, how do we address that gap, either from what we do on the ground level here or through some policy change in Washington?
Well, so if policy change in Washington was easy, it would be much easier to address. But if I were to think about local opportunities to intervene, I think that when we look at our entire system of healthcare in Philadelphia, there was an attempt, I think, through the Affordable Care Act to start to look at engaging hospitals in broader community health efforts, identifying needs in the community, and having hospital systems come forward to help address those issues. And I think, while there's been some efforts in that area, I don't think it's gone far enough in terms of thinking about how all the stakeholders can come forward to try to fill gaps in our system. The city ends up being often the real provider of last resort, and it's important in that role. And to the extent that the city is able to expand infrastructure for healthcare delivery in areas like that, I think is an important part of the solution. But we can't at the same time always just look to the city to fund and fill gaps in the system that exists today. So unfortunately, there's no magic bullet here in terms of thinking about how to address these deficiencies, but I think it's pushing on community health centers as they come forward with new applications to try to locate in areas like this, to the extent that they can be pushed a little bit into more challenging areas, but where they could still become sustainable. Pushing our hospital systems to think about their role as part of community health improvement plans and their community health needs assessments.
Okay, great, thank you.
I'm Marjorie Mecca from Penn School of Nursing. We heard a bit about how the race, the degree of wealth or poverty, and the geographic distribution of the population is correlated with utilization and availability of health care. I wonder if you would also talk about gender. The reason I particularly ask about that is because a disproportionate size of the population that is in the poorer areas generally is women or women-headed households.
Yeah, so I'll just say, based on the sort of a couple of indicators that we talked about earlier, in terms of access to health insurance coverage, as well as having a primary care provider. Women actually fare better than men do. Men are more likely to not have health insurance. They're more likely to not have a primary care doctor, and also more likely to seek care in an emergency department as their primary source or usual source of care. If you were to do so a long span correlation, then life expectancy in women is longer as well. So certainly there is a gender gap there, but another way.
Good to know.
Yeah.
Hi, I'm Markel. I serve with National Health Corps here in Philadelphia. My question is, can any of you speak to the role that school-based health centers play in increasing access to healthcare? And should we be incentivizing or looking for ways to make them more affordable and more abundant in Philadelphia? And if so, how do we do that?
So I personally cannot speak directly to the availability of school-based health centers in the city. It was not a specific measure that we have been tracking at the health department level. It's certainly something to consider. And as we think about sort of where are the other access points for primary care access, having a repository of where those are located and potentially where they could be located as a point. I know the school district has done a fair amount of work to sort of start pushing health as an agenda within the schools directly. And there is a community schools initiative that's happening here in the city to be able to provide and work to merge together sort of the work that happens in education and to support families as well, with a lens of health for those families. But I don't have any hard data from sort of my knowledge base to say, here's the pattern that's happening over time.
But there is a theme here that I think comes back to the same conversation about telehealth, which is to the extent that we can think about situating healthcare in places where people live and work and decrease barriers more generally, I think is an important strategy. And I think technology through telehealth can be used to do that. Physical location can be used to do that. We need to think about, to some extent, we've established systems of healthcare, that are very provider-centric to some extent. And I think we need to, there's a reason why urgent care centers are popping up and retail health clinics are popping up, is people want convenience. And so being located in a school means convenience. It means being embedded in an environment and potentially developing clinical programs that are more responsive to the needs that we're seeing. So I think it's an important point.
I'll just add a couple of points that there's currently actually a program that the Philadelphia Department of Public Health is leading. That's a school-based program focusing on identifying kids in some schools in low-income neighborhoods who have particular health needs. I believe it's related to asthma, ocular health, eye problems, and dental needs. And that's just underway, so we don't really have any information on that, but I think things like that are very promising. There's also been work in the past looking at the costs and benefits associated with school-based health. And most of the work has shown that it's very cost-effective to be able to provide healthcare services in schools. So I think it's especially kind of in an environment with fiscal constraints, it's really a strategy that needs to be considered.
Hey, I'm Jared. I'm a fourth-year medical student. I'm curious, a big problem I see is not necessarily gaps in Medicaid, but gaps in Medicaid managed care companies. I'm curious if you guys, when you guys looked at your Medicaid data and like coverage for primary care, did you look at any sort of gaps when you just break it down by managed care, like whether there are significant gaps for Keystone or for Aetna Better Health or things like that?
Yeah, so I'll say the source of much of the information that we actually produced is national information, and we didn't actually sort of work directly with the health insurance companies to figure out sort of where their particular gaps might exist and where they might have variation within their networks. So this is more comprehensive at the population level. I'm not sure if the data sources even have that information available for us.
So yeah, I mean, that's a great question, because in so many respects, not just in Medicaid, but in private insurance, there's an evolution, particularly like in the exchange products, for example, a little less so here in Philadelphia, but in a lot of other cities, we've seen like very narrow network plans where you just have very few choices of providers. And so that's a really important question, because everything I showed you assumes that you have the full choice of providers that are participating in Medicaid writ large. It does not address the issue of which plan you selected, and because nearly everyone in southeastern Pennsylvania who is on Medicaid is in a Medicaid managed care plan, it matters a great deal what the provider network is for your plan.
Hi, my name's Zach. I'm a student at the University of Pennsylvania. I've been hearing a lot recently about how millennials and Gen Z, it just keeps getting worse and worse. They don't seek out primary care services. And hearing a lot of times they'll forego it or just simply go to an urgent care facility, right? I've heard convenience thrown around as like one of the reasons why they don't go in the first place, but for me that's like a very broad term. I was wondering if you guys are familiar with any research or any cases dealing with the main reasons why millennials and people from Gen Z don't go to the hospital, or sorry, don't get primary care.
Can you tell us?
Yeah, I was gonna say, I don't know. There's a few of you all here.
Yeah,
right.
Give us some insights, though.
Yeah, I mean, the short answer, I don't know
No,
if you have thoughts, but I'm not aware of any data.
No, it's a recent phenomenon. I mean, I think as urgent care and retail, you're seeing more written about it, and I think people are, it's going to be a topic. If you want to get a thesis going, it's a great topic to take. But I thought it was funny when the gentleman I was talking to said, yeah, they paid me, so I did it. So it's kind of, what stimulates people? I mean, for a millennial, it's yeah, if I can get wellness payment, I'll do it, but otherwise.
So there's a interesting, I heard someone who leads a health insurance plan, not here in Philadelphia, but another part of the country, comment on some work that they've done in behavioral health. And there was a study done by a small company that they worked with to offer behavioral health services in a traditional way and then in a more telehealth sort of way. And then I think the third option was to talk to an avatar.
Oh, yeah.
And the avatar won. And not just in engagement, but I think even in some outcomes. So we have a lot to learn.
Thank you. Yeah. Hey, possibly one other piece of the puzzle also is that we talk to our colleagues at the library system, and people go to the library traditionally to check out books. And the library has free internet, and the number one reason that people actually go to the library and their uses of the computers is actually to look up health-related topics. So increased reliance on the internet and other sources might potentially have something to do as we think about how the millennials interact with the internet.
This question is open to anyone since you were discussing millennials. Do you think that the ACGME, in terms of the competencies that they have to learn in terms of system-based learning, were you able to find any links or any ties to what they're teaching in terms of the students in terms of primary care? And leave it open.
Yeah. I'm not quite sure I heard everything.
ACGME, training
in terms of
competencies
system-based learning, since he was talking about managerial care and all that stuff.
Boy, I'm not sure I can answer that.
I mean, I would say all of that, despite competencies being created, if you look at medical education, a lot of it is still in its infancy in terms of thinking about training a provider workforce who knows how to receive the incoming data from Independence Blue Cross, knows how to prospectively manage a population, and of course, you can teach all those things, but when you also enter a workforce that's not engineered to actually practice in that way, then it may also not bear a lot of fruit.
Okay. Bill, you have the last question.
Okay, so I'm Bill Aronson. I am a professor at Temple University in Health Policy and Management. Just as also for full disclosure, I have been more than 20-year a member of the board of directors of Delaware Valley Community Health, and am very much into the federally qualified health centers and regulation, et cetera. The one thing I would like to suggest, first of all, is I think that the concern about the millennials is a little overblown. The reason I say that is because I'm a baby boomer, by the way. I actually remember being the age that the millennials are now. I never went to the doctors, okay? So if I wasn't sick, I didn't go to the doctors. Now, when we started having babies, then we started seeing a doctor on a more regular basis. But until then, and I think one of the concerns with the millennials is that with the increasing prevalence of chronic disease, even among young people, I think that's the population of concern in the millennials, not the healthy ones. Anyway, that's just my own opinion. So I just wanted to throw that out.
That's interesting because I kind of look, what are people in their 30s supposed to be screened for? And there are a large number of things that they should be screened for, one of which is depression. There's, depression and anxiety, because you're hearing that more too. With the millennials, you hear about the stressors that they're undergoing. Hepatitis screening, that's still prevalent. There's other vaccinations. I mean, there are a lot of things that they should be seeing the doctor about, and also to establish that trusted relationship. So, it is a trend, and so I think that it is important for even healthy people to have an established relationship with the doctor. So,
I'm not disagreeing with that. I think it's a good idea. I'm just saying that.
Yeah, but you're right. I mean, you think, what does a 30-year-old go to the doctor? Sometimes they may not go, but they should, is I guess what I'm saying, is they should have relationships with
I find
a
even
PCP.
among the graduate students that I teach, they don't. So.
Yeah. Maybe they should be paid.
And they're graduate students in public health, but that actually wasn't the question that I had. Okay. So, concern was raised about community health centers and also the shortage areas, particularly in the lower Northeast and the Northeast. And you showed that map where the federally qualified health centers are. A couple points that I'd like to make. One is that a lot of the community health center organizations in the city are pretty stable, and they've been around for a really, really long time, and so have their locations. So going to the Northeast would be a new investment. Now, having served so long on the board, and I also know what it takes financially and in terms of investment to open a new clinic that could qualify as a community health center for purposes of payment, of reimbursement from Bureau of Primary Care and also Medicaid and the like. It's a considerable investment, and we're talking in the millions of dollars. We're not talking about a small investment. So I guess the question is, and you also talked about not having a public hospital. I get that part, but remember, public hospitals are owned by units of government. They're owned by county. So in terms of partnership, what would it take, or how could we move in a way to invite maybe the current actors to consider locating new clinics, help with some investment in terms of what the upfront investment cost would be, and identifying particularly important neighborhoods to serve. Okay, and you can start with one or two at a time. It really is not going to take as many as what it sounds like, just simply because of the population draw that we see in our clinics. I was amazed at the number of zip codes that are not in close proximity to our clinics that they come to our clinics to be served. So, it seems to me that there's got to be some actor, and the only one that would be plausible would be the city, Rainer.
You're looking at me.
That's right. I'm looking right at you. To be the catalyst to start that process.
Yeah,
I was really shocked when I saw that map, to be honest.
Yeah, I think you answered your own question. To actually make this happen, it takes really a public-private partnership. I think Health Center 2 on South Broad Street that the city operates is a very good example. Folks have probably seen the new building there. That was a partnership between the city and CHOP, which is in this case a private partner, but also the library, so different facets of the city. Those types of creative partnerships that leverages some of the resources that are within the non-governmental sort of sector, as well as government resources, as well as other sort of foundation philanthropic organizations being involved in sort of developing, sort of mixed-use facilities, really is sort of the key to sort of cracking the nut, so that no one actor feels like they are wholly responsible for creating or addressing the maps that you just saw. And I think that's really the answer to the question.
Okay, great, thank you. All right, Michael, thank you.
That's exciting.
Well, I'd like to thank you all again for attending. I'd like to thank our speakers. They did a marvelous job.